Thank you, Frank, for putting this together. I think it was a great success. It's hard to follow Sanjay Gupta and then Jillian Hatz on the stage, but I'll try. And for those that don't know her, I've worked with Jillian in Miami, my days there, and she's a dynamic personality who is so passionate with what she does, and I think she'll be a great resource. So Bob Sefcik, if you're in the audience, please talk to Jill. All right, this is where I work, Wolfson Children's Hospital, and what most don't know is the hospital is a place where we work, but really the specialists that work there are from the University of Florida, Jacksonville, which is where I'm from, and Nemours Children's Clinic. There's the Mayo Clinic there too, but those are the principal professionals. So my talk today is entitled TBI in Kids, Not Just Little Adults, and that's a trite title for a more passionate about caring for kids with head injuries. And this is a broad audience. I'm used to speaking to a focus group of neurosurgeons about a specific research talk, so forgive me if I maybe go over too many things for some people and not go over as many things for other people. So I wanted to make you aware of the factors that make a pediatric head injury different from an adult head injury. And we'll focus on the physical and social factors. I also wanted to show you that the pediatric TBI as a disease differs from adult TBIs in pathophysiology, epidemiology, treatment, and outcomes. And we'll be jumping around a lot of different topics, so just come along for the ride. So, differences in kids. The mechanical difference is the body of the child is evolving and maturing. So the child starts off with a much larger head in proportion to the body than the adult. And coupled with that, with such a large target, their head, they also have weaker supporting structures. So their bones are immature, their muscles are immature, and that just sets them up for injury. With all of that, not all of their functional systems are online, so their nervous system isn't working right. It's working as it should per their age, but it's nowhere near the functionality of an adult. So as they age, the nervous system continues to mature. So here's an AP and lateral scout CT scan image of a 1-month-old, and you can see how large the head is compared to the chest, and see how flimsy that little neck is, and holding up that, if you said 10-pound bowling ball, this is more like a wrecking ball in a child. And look at how things change just in a few years. The skull gets thicker, the neck gets longer, the bones are heftier, and the body sort of catches up in proportion to the more towards the adult. And a teenager is practically an adult configuration. You see how the skull is much thicker now. Neck bones are much more robust, and the body is much bigger than the head. But what's going on inside? So here's an MRI T2 weighted axial scan of an infant compared to a 4-year-old compared to an 11-year-old. And you can see the changes with time. There's more sulcation or more sulci form in the brain, so there's more folding of the brain. You can also see here these darker gray patches are myelin. So as in the infant, there's very little myelin in the brain, and as the brain matures, more and more myelin gets deposited. And with the development of the brain comes the progress in their developmental milestones. So, to recap, here's some developmental factors that come into play. So an infant has poor fine and gross motor development, so they're more prone to fall. They're more prone to get into things. But behaviorally, they're not rational, so they're very hard to, they can be very hard to console, which predisposes them to a disease that I'll talk to you next. In the teen, it's very different, as most of you know with teenagers. Their executive function, the frontal lobe is elastomyelinate, and with that comes executive function. So, judgment can be a problem, and coupled with that, once they hit 15, they start driving. So you have these people with poor judgment on the road. And so that's a recipe for disaster there. All these, in childhood and adolescence, they're not working, but their occupation is a student. So you must remember that they actually have more important work than we. They're developing their brains. Okay, so to shift gears a bit, and some of you have alluded to this already. So this is the 2010 CDC publication saying that approximately almost 1.7 million TBIs are recorded in the U.S., but who knows how many are not. The bottom of the pyramid there, all those mild and very mild concussions, they never make it to the ER. So who knows what the true denominator is. But looking at age group incidences, we'll spend a bit of time on this slide. Here are the emergency department visits, and they're highest in the pediatric age group. Highest in the pediatric age group. And you can see the numbers there, 400,000, almost 500,000 ED visits alone. They highlighted the older adults here because that's the second highest incidence of traumatic brain injuries. Sadly, the most this age group has the most fatalities due to head injuries. But we're all concerned about, and rightly so, the father that gets injured, the Iraq War veteran, the NFL player. But look at how many other folks are victims of head injuries that we're not even capturing. And there's sort of a good and bad reason to that, which we'll get to in a minute. But if you break it down to cause, falls are the most common. Kids less than 14. Sadly, 3% of them get assaulted, and a lot in the very, very young, which we'll talk about. But they kind of parallel falls, motor vehicle accidents as well. So the children and the elderly sort of have parallel TBI causes almost. So to summarize the last few slides, the children have the highest incidence of traumatic brain injury by far. They're more frequent than adults. The reason why they may not get as much press is they're less fatal than adults. So more kids have maybe less severe head injuries, but then the converse of that is there are more survivors for traumatic brain injury in kids than in adults. So there are more kids walking around who've had traumatic brain injuries than adults. And that's not something that people really think about. Falls are most common in young kids, and MVAs is the most common in teens. But in children, traumatic brain injuries is one of the leading causes of death and disability. So this is a very important problem that maybe people don't know as much about. So abusive head trauma. So I wanted to spend a few slides on this because I figured that this would be a topic that was not talked about a lot today. Abusive head trauma is defined by the CDC as injury to the skull or intracranial contents due to inflicted blunt impact or violent shaking in children less than 5. And in kids, in infants, it's one of the leading causes of hospitalization and death. So this is assault. You're assaulting somebody's assaulting a helpless baby. And among the head injuries in kids, this has one of the highest mortality rates, abusive head trauma. And of those that survive, they're severely, severely disabled. So it's a real problem. It's not nice to talk about. It's not sexy like concussions in football. But this is a big problem. This is a kid that we just took care of the other week. This child was born premature, was in the neonatal intensive care unit for probably 8 weeks, went home, and 3 weeks later was in our emergency room for failure to thrive. So the kid was only home for 3 weeks, and the father inflicted this on the child. And we can do what we can as neurosurgeons. We converted what would have been a near fatal or an almost fatal case to one where the kid survives. But what we did was we took out half of the skull. We did a decompressive hemicraniectomy to give this child a chance to live. But what outcome is this child going to have? If there are any lawyers out there or people who can influence the legislation, oftentimes I feel the laws against the perpetrators are too weak. Too many of these kids, or too many of the perpetrators don't get locked away for long enough. But there's some differences that can be made. Mark Diaz is a pediatric neurosurgeon who was up in Buffalo, and he had this simple sort of public health project. Basically, he looked at live births for a 5.5 year time period in Buffalo, and he just instituted this simple educational project. He taught all of the nurse managers in all of the birthing units, who taught then all of their nurses, and provided the nurses with a video, a pamphlet, and a contract. And the nurses then went to all of the fathers and said, while the child was still in the hospital, they sat down and talked to them about what causes shaken baby syndrome, how to prevent it, and they had them sign a contract to say, I will not shake my child. And just that simple intervention, well, yeah, here's the clause in the contract. I received the educational material about shaken baby syndrome. I understand violent shaking is harmful and potentially deadly to baby. I agree to participate. And what they saw over time was kind of remarkable. More than, this was before the contract and the study was done, and this was the years after, or the years when they were doing the study. And marked reduction in the incidence, and just by a simple public health type intervention. So, and I've been thinking about this. We all talk about treatment, but and Jillian kind of talked about it as well. I think prevention makes a bigger difference than treatment, and this is huge. This is something that we need to implement here in Florida. A bit about treatment, and as a neurosurgeon, I could talk to you for 2 hours or 3 hours about treatment, but I just wanted to summarize the goals for the audience. Basically, the principles, whatever form of injury you get, the principles are the same. You address a primary injury and minimize a secondary injury. So these are all different forms of hematomas. If they're large enough, causing pressure on the brain, you go in and take the hematoma out to prevent it from secondarily injuring more of the brain. This is what we do. Bread and butter. We go in, either take out a blood clot. If there's a fracture that's on the brain, you sometimes elevate the fracture, clean it up, and if there's very severe swelling, then we take a large part of the cranium off to offer more space for the brain and decrease the pressure. And those are all, in terms of medical treatments that we do, I would think are in this day and age, are still fairly primitive. I mean, the techniques have gotten better, the tools have gotten better, but really what we're doing is we're just doing damage control. We put in some tubes in the brain to drain spinal fluid and monitor intracranial pressures. I'm not knocking what the treatments that are out there, what they achieve. It's just that the progress that's been made in acute treatment of traumatic brain injury, I think, it hasn't advanced further in medicine versus other treatments, let's say for cancer and stuff. One of the documents that's put out by the Critical Care Society is these guidelines. The second edition came out last year, and if you read the second edition and compare it to the first edition that was out 10 years ago, really the recommendations are about the same. So that kind of says a lot for the treatment. It's a very important treatment, and we are saving lives. But I think now, it's important to focus on the quality of the lives that we're saving. There's been active research in the treatment for traumatic brain injury, particularly focused on preventing secondary injury from a surgical standpoint. And these are two, and I summarize basically in this slide maybe 15 years of research. In hypothermia, there are various prospective trials on adults and children, and basically they have not found any evidence to show that hypothermia improves outcomes in traumatic brain injury. In stroke, yes, but not traumatic brain injury. And decompressive craniectomies, like what we did to this child that I showed you earlier. It's a very effective treatment at decreasing intracranial pressure, but there's no evidence to show that it improves outcomes. So we're kind of missing the time to intervene here, and practically there's almost no time to intervene, because once the trauma happens, that's it. The brain is injured. And what we're doing is just trying to prevent more injury from happening. But there are more trials ongoing for the decompressive craniectomy, so that's more to come from there. So let's talk a bit about outcomes. Florida Gators. Again, the tail end of this graph. This is mortality now. The tail end of this graph looks like the other graph, where most of the deaths occur at the very old end of the spectrum. And again, the younger kids, most of them survive. But if you remember the previous graph, the ER visits were all the way up to here. So you have all of these people that survive, that have head injuries, that are walking around. And that's much harder to quantify, and it's much murkier to see if the learning disability that they're having now is related to the head injury that they had as a child. It's much more difficult to prove. Just a slide to point out that in children, the kids who are symptomatic their symptoms tend to stay on longer than the adult. So, in this study of 197 kids with mild TBI, 51, about half of them still had symptoms at 1 month. At 3 months, about 11% of them still had them. And Dr. Hutz went over this, but the kids who are older than 6 have a higher incidence or a higher likelihood of having persistent symptoms. So, here it breaks down to this is older than 6, this is younger than 6, and look at the time since injury. 400 days, 500 days. About a third of these kids still have symptoms. And also, if they've had more severe concussion, then they can have symptoms. So F is the most severe type of symptom, and concussion, and A is the least severe type of concussion. But and I want to point this out in children. You hear about the NFL athlete who gets hit, and they're out for 2 weeks, and they're back. Baselines are good, and they're back. In children, I suspect that it's not the same. Their symptoms last much longer than your professional adult athlete, and that's another quandary for all of these return to play guidelines, because all these young kids want to go. Their parents want them to go back to play, but then their symptoms aren't cleared yet. Jillian talked about this, a second impact syndrome. It's fairly rare, but it happens, and thought is that the first hit is a mild traumatic brain injury, and then shortly thereafter followed by a second hit, and the thinking is the second hit comes before the symptoms resolve, and what they find is there's malignant cerebral edema that occurs. So malignant brain swelling that causes certain disability or death in these kids. And there are lots of theories that are out there. Because it's so rare, it's not been well studied. They think that it may be due to loss of cerebral autoregulation of the vasculature. Jillian talked about Zach Lystet, who was in Washington State, 13-year-old, shook off his first mild head injury, went back the second half, and collapsed. He survived following heroic surgery, but was severely disabled. And the feeling was he returned to play too early. And she talked about the Lystet law, which forms the prototype of all the other laws that followed. When I reviewed this subject in 2011, there are about half of the states had some form of law similar. And this is from the Law Atlas website. There are only 5 states in the union, but Jillian says there are 48. Basically, most states have a similar law, which Florida has as well. But I want to tell the audience that not all concussions are mild head injuries, but not all mild head injuries are concussions. And that may be one of the reasons why these mild head injuries get a second hit and do really bad. This is a cute little girl that fell down the stairs, was brought to the emergency room, and she didn't lose consciousness, and she had a Glasgow 15. On her CT scan, there's just a small fracture here on the temporal bone, and she has this large epidural hematoma. And so, she started off as a Glasgow 15, but if we waited too long, then she would have deteriorated and maybe died. And she was brought in because the family was just nervous. But you think of all the families that sort of just blow things off and how things can spiral down. So if you think about all of those mild head injuries that were there in the other graph, how many of those are these? You don't know. Moderate to severe head injuries, much can be said about these, but what I wanted to focus on are the survivors. This is a meta-analysis of the neuropsychological outcomes in children following head injury. So this is the control. The solid black is the control line. The mild head injuries are these dots, and you can see that they start off, their functioning is lower than the control, but over time they're able to catch up and finally catch up with their peers. With the moderate head injuries, they start low and they stay low. They get better, but they never really catch up with their peers. The severes start low and go even lower with time. They don't get better. Where does that show up in school? So academic problems may surface years after the traumatic brain injury. Personality changes up to 40% in kids after severe TBI. Behavioral problems in 22% and 36%. So it's not just how they think, it's how they act. So to close, kids are not just little adults in terms of their TBI. Traumatic brain injury is most common in children, and it's one of the leading causes of death and disability. The developing brain and cranium makes them vulnerable, not just to head trauma in general, but to abuse, and outcomes show up in school. And kids with mild head injuries can have longer symptoms and beware of the second impact syndrome. Thank you.